So today we will be taking up an important topic in the thorax, and today our topic will be mediastinum and its clinical implications. The clinical conditions associated with the mediastinum. So as far as the mediastinum is concerned, you have to remember that it is a very important region, a very important part of the thorax, and it forms a communication between the neck and the thorax, and there are structures which come from the neck, go into the thorax, and this mediastinum happens to be a very important region because many structures remain within the mediastinum. As far as the mediastinum is concerned, you have to remember that we have to divide the mediastinum into various parts. And first of all, what are the boundaries of the mediastinum? This mediastinum, as you can see in the figure, you can have a look and you can see that it has got an anterior boundary, it has got a posterior boundary, it has got a superior boundary, and it has got an inferior boundary. The anterior boundary is formed by the bone over here, the sternum, and this is the sternum, and the posterior boundary is formed by the vertebral column, and the superior boundary is formed by the thoracic inlet, and the inferior boundary is formed by the diaphragm. So these are the anatomical boundaries of the mediastinum. Then after that, we divide the mediastinum into superior and inferior parts. And what is the line of cleavage? What is the line of division? The line of division is formed by what we have over here. We have got the manubriosternal point, and in here we have the T4 vertebra, and we draw a line from the angle of Louis to the T4 vertebra, and the area above is given the name as superior mediastinum, and the area below is given the name as inferior mediastinum. So basically the superior mediastinum and the inferior mediastinum, and then we divide the inferior mediastinum into three parts, and one is the anterior part over here, and this is the middle part, and this is the posterior part. The heart along with the pericardium is the occupant of the middle mediastinum, and the area in front of the heart is given the name as anterior mediastinum. The area which is enclosed by the heart and the pericardium is the middle mediastinum, and the area which lies posterior to the heart is the posterior mediastinum. So these are the three divisions of the inferior mediastinum. That's one. Now, as far as the mediastinum is concerned, we are frequently asked about the contents of the mediastinum. So as far as the superior mediastinum is concerned, you have to first of all remember that the superior mediastinum is anteriorly bounded by the manubrium sterni. This is the manubrium sterni, and over here by the line which I just mentioned you, from the manubriosternal angle to the T4 vertebra, and over here this is the thoracic inlet. So this is the superior mediastinum, and in the superior mediastinum you have got certain important contents, and the contents of the superior mediastinum which we will be discussing are divided into multiple components, and the components are the muscular component, the arterial component, the venous component, and the lymphatic component. So first of all, you remember that there are those two important muscles. The one is the sternohyoid and another is the sternothyroid, and in addition to longus colli. So sternohyoid, sternothyroid, and longus colli muscles. Next slide please. Sternohyoid, sternothyroid, and longus colli muscles happen to be the, could you minimize? Happen to be the contents of the superior mediastinum. Now, in addition to that, you have to remember that there is this aorta and the branches of the aorta which lie within the superior mediastinum. In addition, you have to remember that we have got the superior vena cava, which is formed by the right and the left brachiocephalic veins. The right and the left brachiocephalic veins, they unite, and the lower part they just unite, but you have to remember that the upper part of the superior vena cava and the right and the left brachiocephalic veins, they form a content of the superior mediastinum. That's important. Then you have to remember the nerves, the vagus, the phrenic, and the cardiac nerves, and the left recurrent laryngeal nerve. So you have to remember the vagus, the phrenic, the cardiac nerves, and the vagi and the left recurrent laryngeal nerve, they form the content of the superior mediastinum. In addition to the gland, the thymus gland, and the group of lymph nodes, the tracheobronchial and the bronchomediastinal group of lymph nodes, they all lie within the superior mediastinum. So these are some of the important structures in addition to the esophagus and the trachea and the thoracic duct. So you can see over here, you can see this is the trachea, this is the tracheal bifurcation, here is the esophagus, in between the esophagus and the trachea is the tracheoesophageal groove, and you have the thoracic duct as well. And as I mentioned, archivolta and some things which are not mentioned here, so you have to remember all those things in addition to the nerves which I mentioned, be content of the superior mediastinum. Now coming to the anterior mediastinum, you have to remember that the anterior mediastinum, coming back to the figure. So could you please enlarge it? So this is the anterior mediastinum, and you have to remember that this anterior mediastinum, there is a ligament which just binds the heart, the pericardium, to the inner surface of the sternum. We give the name to them as the sternopericardial ligaments. So sternopericardial ligaments are the content of the anterior mediastinum, in addition to some loose areolar tissue and a group of lymph nodes and the thymus gland. The thymus gland also lies within the anterior mediastinum. Now the heart, coming to the middle mediastinum, this is the heart along with the pericardium, and in addition to that there is the pulmonary artery and the pulmonary trunk, the pulmonary arteries and the pulmonary trunk, which also lie within the middle mediastinum, in addition to the phrenic nerve, in addition to the deep cardiac plexus. You have to remember that we have the cardiac plexus, the superficial cardiac plexus and the deep cardiac plexus. The phrenic nerve and the deep cardiac plexus lies within the middle mediastinum, in addition to the tracheobronchial group of lymph nodes. So you have to remember these important structures which form a content of the middle mediastinum. Now coming to the posterior mediastinum, which is a bit more heavily occupied, and the posterior mediastinum has got the esophagus. The esophagus comes from above downwards along with the descending aorta. So the descending aorta, the descending thoracic aorta and the esophagus, in addition, so you can see over here, this is the descending thoracic aorta. It forms an important component of the posterior mediastinum. This is the trachea which comes down, this is the esophagus which comes down. In addition, you have to remember that the whole venous component, the azygous vein, the hemiazygous vein and the axillary hemiazygous vein, they form a venous component of the posterior mediastinum. Yeah, I told you vagus. Vagus comes from above and goes down, and this vagus also forms a component of the posterior mediastinum. In addition, you have to remember the great splanchnic nerve, the lesser splanchnic nerve and the least splanchnic nerve. All the three splanchnic nerves, they also form a component of the posterior mediastinum. So you have got these important structures in addition to the thoracic duct, which also forms a component of the posterior mediastinum, in addition to the posterior mediastinal group of lymph nodes. So there are many lymph nodes scattered in the posterior mediastinum, and these happen to be some of the important components of the posterior mediastinum. So this is something about the contents of the mediastinum. So why do we study this mediastinum? That's important. You have to remember that. Yeah. Now, as far as the anatomy of the head and neck is concerned, you have to remember that we have got this deep cervical fascia of the neck, and there are multiple components of the deep cervical fascia of the neck, and one of the component which lies in front of the vertebra and another component lies in front of the trachea. So this over here is the vertebral column, and in front of the vertebral column is the prevertebral fascia, and as you can see that this prevertebral fascia is also present in the mediastinum, and spirally it communicates with the neck. And in here, this is the pretracheal fascia, a fascia, layer of fascia which lies in front of the trachea. This is given the name as pretracheal fascia. So we have the prevertebral fascia and the pretracheal fascia, and what is important about the pretracheal and the prevertebral fascia is that they communicate the neck with the mediastinum, especially the superior mediastinum. And in case there is an infection in the region of the neck, minor infections of the neck, they can rapidly progress, and they can just get more extensive. And what can happen, the pus from these infections, there are many conditions in which the pus can drag down. There are multiple numerous infectious conditions from the neck area which can just drag and trickle down the prevertebral fascia and the pretracheal fascia. So you can have the infections of the neck spreading through these two layers into the mediastinum, and they can just cause severer problems in the form of, in case the pus ruptures, and we can have a full-fledged, full-blown picture of mediastinitis. Mediastinitis is infection or inflammation of the mediastinum as a result of many conditions, but in here these neck infections, they can be one cause, and mediastinitis has to be a very severe infection with a high rate of mortality. So you have to take care that the infection does not spread into the mediastinum. You have not to allow the neck infections to progress to a stage to which they can cause mediastinitis as a result of tracking down through prevertebral and pretracheal fascia. So that is important. That is this figure over here. So this is one of the important clinical implication of the mediastinum and its infection. Now, as I just mentioned you before this as well, the conditions which cause mediastinum. So we can have descending mediastinum, we can have direct mediastinum, we can have ascending mediastinitis. So the mediastinum can be infected from infections from above or infections from below. So that is, so as I mentioned, infections from due to cervical disease, neck trauma, dental procedures, direct through esophageal perforation or cardiothoracic surgery. These are all iatrogenic causes. So, and infections of the retroperitoneum, they can go high. So we can have ascending infections, we can have direct infections, we can have descending infections, just to mention a bit. Now, sometimes what happens, despite so many scanning techniques, MRI, PET, CT, we cannot evaluate and come or arrive at a diagnosis of certain conditions. And what a team of doctors does, they do just an inspection of the mediastinal region, and that procedure where we insert a probe with a tiny camera fitted at its tip, a high resolution camera, a flexible usually used. So this is the technique which is given the name as mediastinoscopy, because opening up the mediastinum happens to be a specialty of specialized surgeons. A general surgeon invariably cannot operate upon the mediastinum, and you have to take care about this thing, that this may be sometimes asked image-based question, mediastinoscopy. So mediastinoscopy is the technique of visualizing the inside of the mediastinum without opening up the whole of the mediastinum, to just evaluate what is going on within the mediastinum, the relations and the structures and any abnormal things you find in this area. So that's important. Now, as I mentioned you, this mediastinum is a very delicate space, many structures clubbed together, and we can have a whole range of conditions which can affect the mediastinum. And what we can have many things. What we just say, we can have, say, I told you pericardium, there can be pericardial cysts. So we can have the lymph nodes are spread in the whole of the mediastinum, and any disease which causes generalized lymphadenopathy, lymphomas, whether Hodgkin's or non-Hodgkin's type, that is some issue for specialists over here. Then we can have the tumors, the teratomas, the thymomas, or the thyroid tumors, which can just be seen in the mediastinal region. In addition, we can have the cysts, the bronchogenic cysts, pericardial, I already mentioned you, the this pleuropericardial cyst, and vascular masses as well. In addition, you can have aneurysms, the antrixes, the esophageal diverticular, esophageal tumors, and neurogenic tumors over here. And this is something about the growths, the cysts, and other structures which you see in the mediastinum. One important thing which I would just like to mention here, and it is always asked, is what we mean by mediastinal syndrome. And what is this mediastinal syndrome? So the functional implication of the mediastinum is that it is an area which is having many important structures within it. Say the esophagus, say the trachea, say the recurrent laryngeal nerves, say the phrenic nerves, say the intercostal nerves, and you have the vertebrae as well. And what can happen? There can be a compression of all these vital structures. There can be compression of the esophagus, there can be compression of the trachea, there can be compression or erosion of the left recurrent laryngeal nerve. So a patient present with Say dysphagia, difficulty in swallowing food. Say dyspnea, difficulty in breathing. Say dysphonia, in case the left recurrent laryngeal nerve is damaged. He or she can be having hoarseness as a result. So these 3 Ds, dysphagia, dyspnea, dysphonia, they can be a result of compression within the mediastinum. So these are compression syndromes. In fact, some patients can come to you and present with facial blushing, engorgement of the veins of the upper limb and the face. And these are the symptoms of superior vena cava obstruction. So important, you can have the superior vena cava compressed, you can have the esophagus compressed, you can have the trachea compressed, you can have the recurrent laryngeal nerve left side especially compressed, or you can have the phrenic nerve compressed or erosed that can cause paralysis of the diaphragm, or you can have the compression or affection of the intercostal nerves causing intercostal neuralgia. So that's important. So all these things, in addition to one, sometimes these tumors, the lung tumors, they can spread and they can cause erosion of the vertebral bodies. So you can be having features of vertebral metastasis in here. So these all together or in isolation comprise something which we call as the mediastinal syndrome. A patient can present with any of the combinations. So a patient with a mediastinal syndrome can have dysphagia as a result of esophageal compression, dyspnea as a result of tracheal compression or an intraluminal lesion, dysphonia as a result of erosion of the left recurrent laryngeal nerve, diaphragmatic palsy or paralysis as a result of phrenic nerve palsy, or erosion of the vertebral bodies as a result of metastatic lesions from any source, or flushing of the face or engorgement of the upper limbs as a result of superior vena cava obstruction. So these things you have to remember in nutshell. What are the anatomical boundaries of the mediastinum, what are the subdivisions of the mediastinum, and what are the important clinical conditions associated with the mediastinum. I hope this class will help you a lot in your preparation for your exams. Wish you best of luck. Thanks a lot.